woman over 40, and maybe even younger than that, you're definitely thinking about hormones, and if you aren't, you really need to be. So I'm very excited to dive into this incredibly meaty topic about two pretty significant transitions that women do go through starting at around the age of 40, perimenopause and menopause. And I want to begin this conversation by level setting about what those two words mean, because they are different words. A lot of times they get conflated. People tend to think it's just like one long continuum. Oh, no, 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 no. You really need to understand what is going on during each phase. So Dr. Senemar, I'd love for you to break down the important distinctions and why we need the two words and are not just using one word for these phases.
Thank you for starting with that, because I think once we set the groundwork in terms of terminology, definition, it makes things a little bit clearer for us to understand what's actually happening. So let's start with perimenopause, which is that big word we're hearing a lot about these days. And that is the time frame where your body is changing, it's shifting, and you have hormones still, your ovaries are working, they're just not as regulated as they used to be. The reason for this is when you're in your late 30s, early 40s, this shift can start to happen, and it can last between 5 to 10 years. So it's pretty significant that we kind of tune in and understand what's going on in order to be able to better take care of ourselves. Menopause is I like to call it the easier side of the equation, because
I don't know, I would dispute that.
in terms of like understanding what's going on, I think because you stop having a period. That's what we know. Menopause itself is really one day in your life, and anything after that is considered postmenopause. So menopause, one day where you haven't had a period for 12 months. That's it. So the distinction is really, you need to hone in on that in order to know what's going on in your body.
And we're going to dive more deeply into both of those transitions. But Dr. Tolentino, I'd love for you to even go further back, because I know that a lot of these changes can appear as early as your 30s. So if you are in your 30s, what do you need to start paying attention to? What is going to be out of the ordinary that maybe you want to say, hey, something is going on here?
Honestly, I would pay attention to all the things, because in perimenopause, it's a rocky road. It is a constellation of symptoms, many different symptoms, and not every woman experiences the same thing. So we all have our own unique footprint for what that might look like in perimenopause. And I think that's where there's, I guess, if you were to group them, there's probably dozens and dozens of symptoms that women in perimenopause experience, and it's not just one thing. So if we're talking about brain fog and headaches, or we're experiencing weight gain and slowed metabolism, if we're noticing immune issues, if we're noticing hot flashes, if we're noticing vaginal dryness along with irregular menstrual cycles, I would say that there are many, many different symptoms that could be grouped collectively as being perimenopause. And that's where there's a lot of confusion, because people will see a doctor who might just be looking at the headaches or might just be looking at the weight gain, but not taking a step back to recognize that holistically, this person might be in perimenopause.
You mentioned this idea of confusion. I think part of the confusion is that until about 2 or 3 years ago, I personally had never even heard of the word perimenopause. Certainly when I was in that age demo, I never had a doctor say to me, by the way, you might be in perimenopause. All I kept asking was, do you want to preserve your fertility? Do you want to have a baby? There was no conversation around, because by the way, you're about to go through this epic shift and all of these things are going to start happening. Why do you think the conversation is finally changing, and why was it silent for so long?
Well, let's go back in history. Menopause equates aging, and who wants to, be that? And it was a taboo. It was a huge taboo. You're in menopause, you're not fertile anymore, right? Because it's all about reproduction with women. Again, these are narratives that need to be shifted and changed, and that's what we are here for in rooms like this. We're making those distinctions. We're more than that. Women are more than just for reproduction. There's more to be done with our time, with our mind, with our bodies, with what we can achieve. So we haven't been really even as healthcare providers, we weren't trained on this. This wasn't a conversation. A lot of the women you see in this space right now, we were all part of the generation when the WHI study came out that basically put a kibosh on everything overnight, where hormones are bad, they cause breast cancer, heart disease, and stroke. So because of that reason, training was minimal at best. So what has happened is, we are not a quiet generation. We are not going to suffer in silence, and we're talking about it more. The taboo is shifted. There's more to be done, and that's kind of, I think, why there's so much out there.
And you mentioned this idea that we're talking about it more, but that maybe our doctors have not caught up. And I think specifically with perimenopause, again, because I think it's not something that's part of the routine conversation you're having with your doctors. Dr. Tolentino, if you are in this demographic, what is the conversation to be having with your doctor? Is there some symptom that should precipitate a conversation, or is it just like, hey, I'm 40 now, thinking about perimenopause?
Yeah, I mean, taking a good stock and an inventory of what your unique experience is like, that is step number one. Because the more that you can advocate for yourself and you can mention how long different kinds of symptoms have been going on, that's helpful data and helpful information for whoever you're seeing. The changes in your menstrual cycle are equally important, right? So looking at what kind of cycles are you having? Are you noticing that you're experiencing a lot of clots? Are there irregularities? Are there any PMS type symptoms that can kind of go along with that? But raising your hand and actually mentioning what these symptoms are and how long they've been going on is step number one. Step number two is reminding your doctor that, hey, I'm experiencing this, these are the symptoms that I have, and I think I might be in perimenopause. It's okay to have that conversation. It's okay to speak up and say that, because as we normalize the conversation and we bring this up to our practitioners, I think more and more doctors are becoming more open and educated and curious to what patients are bringing forth. And if you aren't getting that experience when you see a doctor and you feel shut down, find a new doctor.
Dr. Senemar, can you give us the kind of menopause 101 of what exactly is causing all of these symptoms? What is driving the transition?
So in perimenopause, it's really progesterone. It's all your hormones. So we have progesterone, we have estrogen, we have testosterone. In perimenopause, what begins to happen is your progesterone starts to fluctuate, then follows estrogen, and then comes testosterone last in menopause. So this fluctuating level of hormones is really what drives a lot of the symptomatology of what women are experiencing. You know, we hear women talk about they're not sleeping well at night. They're short-tempered with everybody, you know, at home, at work, with their kids. And they know it's not them. They're like, this is not my baseline. Something is off. I don't feel like myself. We hear that, I don't know how many times a day. And the other part is anxiety out of nowhere, where they never had anxiety in their life, and now it's, you know, popping up over things that doesn't make any sense. And a lot of other women who have ADHD that is well controlled, all of a sudden becomes more of a problem for them. So these are all due to this fluctuating shift in hormones. The highs and the lows is what's really throwing you off. And that's why in perimenopause, it's really critical for you to take stock of those symptoms, have a symptom diary, and bring it up to your healthcare provider, because if it's affecting your quality of life, we need to have a conversation.
On the internet, you see a lot of phrases like hormone balancing and hormone testing and things like that. Is there a test that you should be taking or asking your doctor for, Dr. Tolentino?
Ooh, how much time do we have? I mean, testing can be nuanced, and there are different ways to look at hormones. Some practitioners will take a look at it in the blood. They're looking at serum levels. There are other practitioners that find looking at how you metabolize the hormones to be helpful, and we typically are looking at urine testing. And then it gets even more complicated because there's also salivary testing for hormones. So some of the more accurate ways that we look at hormones like cortisol is actually through the saliva. So it is a nuanced chapter when it comes to lab testing. But, you know, finding a practitioner who's going to help you understand it in an intuitive way is super important. And for some people, they may have access to just looking at the blood and understanding it that way. But if you have the capabilities of taking a look at it in different ways, it can be helpful for moving forward.
And what do these tests actually reveal? Like, do you get a diagnosis of perimenopause, or is it you're low on estrogen? Like, what are you looking for as an outcome?
Yes, so you can see those levels in the different avenues. Like, you can see low levels of hormones. You can see metabolites of certain hormones. You can even look at rhythmic shifts, like looking at a pattern of cortisol released throughout the day. So it can give you diagnoses, but it's never just finite, meaning just looking at labs. You are always pairing it with a human being in front of you. What kind of symptoms that person is experiencing? What is their medical and family history that's pertinent to the discussion? So it's never just the data. And it was never about that. It was about looking at the whole human and really recognizing that labs was just one tool in the toolbox.
So, Dr. Senemar, you find out that you have some hormone changes that indicate you are starting to transition. Is perimenopause an appropriate period to consider menopause hormone therapy, or is there some in between that you should be thinking about?
What I want women to understand when they come in and we have this conversation, we do the full intake and we do testing. And I like to do testing because women want data points. And so I also, we look at the thyroid dysfunction and also iron deficiency, things that can also mimic a lot of the perimenopausal symptoms. And once we rule everything out, then we have a conversation. Then I dig down into, okay, let's talk about our pillars of health. How are you sleeping? What does your stress level look like? Are we managing all of that? Because I don't want women to think hormone therapy is the end-all, be-all magic bullet that's going to fix everything. It doesn't work that way. It takes everything. So the foundation has to be set before you can add on supplements, before you can add on hormones, before you can add on peptides or whatever have you out there. There's longevity medicine happening now. Precision medicine is really what it's about. So you want to make sure the nutrition component is addressed appropriately. Whatever you're eating, let's break it down. Let's have a conversation. What does your day look like? Bring me that. Maybe you're not getting enough protein. We talk about protein all day long, and we can go off on that for a whole hour, but we won't bore you with that. But it is a conversation to have because women think they're getting appropriate amounts of it, and then when you break it down for them, they're like, oh my goodness, I'm deficient in this. And as you heard from the GLP-1 panel, you need that protein to maintain your muscle. And you need that muscle to maintain your strength going forward. So we are, you have to hone in on the diet. You need to hone in on your movement pattern. What are we doing? Are we working out? We're all cardio queens here, that generation. And we need to get out of that mindset. We need to start lifting weights. We need to add in strength training, flexibility, bring it all together. And I meet my patients where they're at. Some of them have never stepped foot in a gym. They've never touched a dumbbell. Okay, let's start slow, and we're going to build upon that. Others have worked out all their lives. We're just going to improve upon it. Okay, I do body composition testing, just like Dr. Salas Whalen was talking about. I want to know your muscle mass. I want to know your visceral fat. And how do we reverse that if it's not the right ratio? Because it's not about BMI really anymore. It's not about the weight. It's about what is happening internally, because women tell us, my body doesn't feel like me. This isn't something shifted. So all of that has to be in order to add on hormones. And you asked, sorry, that was a winded way to get to the answer. Yes, hormones can be part of the equation in perimenopause. I don't want women to think, I need to be in menopause in order to get my 10 years worth. No, you can start in peri. Let's say you're 46 and you're having symptoms and your diet is dialed in, you're working out, you're fit, everything's great, but you still don't feel well. Now we're going to experiment with some hormones and see how we can get you to feel better.
And that's really a very different way of thinking about hormone therapy than, even just a few years ago. Another different way that people are thinking about hormones is when it relates to breast cancer survivors. And Dr. Tolentino, I know that you yourself are a breast cancer survivor. Can you share what the conversation used to be and how you see it evolving?
Yeah, honestly, there was no conversation. And I think that was the problem. The problem is that there was no conversation. So I had breast cancer in my early 30s. This is back in 2016. And completely, immediately shut down. You mentioned the word hormone for somebody who's had a hormone-positive cancer, and they say, oh, we're not going to go there. That's not part of the conversation. Immediately dismissed. And for somebody who's having such a terrifying experience, to hear that, it was disheartening to say the least. But I think there's also some disappointment in the medical community to not recognize that this is still a part of our story. And for those of us who have had breast cancer, it still is a part of our story. We should still be able to talk about hormones and learn about them. And if we do decide, with the unique perspective of me and my provider, that it's still something that I want to engage in, that should be on the table too. For so many breast cancer survivors that I've seen oncologists, even now in the year 2025, they will still shut down the conversation. And I'm really disappointed in what I see. Even me myself, who with my own oncologist have experienced that. And the more and more that we raise our hands and that we have these conversations, that we build communities that are empowering women, even those that have experienced breast cancer, this is where it starts. It starts with conversations like this, to say, you know what, I'd like to still have this conversation with you about hormone therapy and what that could look like for me, or not. Are you willing to engage in this conversation with me? And let's see, right? The tide is certainly changing and it's evolving. And with medicine, we see that hormones do not cause breast cancer. And we're having to fight and kind of rewire the narrative. The narrative for the last 20 years has been the opposite. And so many more women are now coming forward and advocating and saying, no, no, no. There is an issue with the data. There's an issue with how it was marketed. And as I've done my own research, I'm realizing that's not the case. And so, it's communities like this that really get that ball moving.
Absolutely, and I love that we are providing, thanks to doctors like you, all the information you need to go and have the conversation with your doctor. But I do think, Dr. Senemar, it's a tongue twister for me. I do think that, the reality is most of us see our OB-GYNs once a year, and we get 15 minutes, and we have to do the breast exam and the pap smear, and then it's like anything else as they're rushing you out the door. So how do you get to even engage on these topics? Do you have any advice for making sure you can have this kind of conversation?
So that's a great question, because, and it's a big concern, because you're right. It's all about the bottom line. Insurance companies, how many patients do you have to see in a day? And so things are shifting even on that front. So let's say you are with your healthcare provider that you love, that is well-versed, and they do want to have the conversation. Make 2 appointments. Do your annual checkup. You go in, you do your pap smear, you do your breast exam, you do all of that, and make a follow-up appointment to discuss these symptoms. So I want to have a menopause consult, okay? So you can have 2 visits to address everything. Now, a lot of us, personally, I basically blew up 23 years of a career, and I'm transitioning to a new practice where I just built it around midlife women. And that's all I'm gonna do, and I give as much time as they need. So between 30 minutes, an hour and a half. That's what you want, that's what we're gonna do. And so a lot of us are going in that direction because we want to have the conversation. Women wanna be heard. That's 50% of the battle. I have women coming to me and just listening, for me to listen to them air out all of their symptoms, they feel relieved. They're like, okay, I feel great. They forgot about the hormones. They're like, I'm great, thank you. I'm like, but wait, let's actually get to the medical part of all of this. So that's where we're headed. So there's traditional model insurance, there's concierge care, there is telehealth companies now who are doing this on a national scale. So we are moving this in the right direction to try and help as many women as possible.
Thank goodness for that. Did you want to build on that?
Yeah, I mean, working outside the model, it's unfortunate that some of us have to do that, but in order to really dedicate and spend the time that I wanted to have with patients, it was a necessity for me. And that meant that 15-minute visits needed to be in my rearview mirror, because in order to really get down to the depth of the conversations that we want to have with women about truly what's going on and not just the surface level, we really needed time. And you know, for many practitioners, I feel fortunate that I'm in a practice that allows me as much time as possible to spend with patients. So our visits are typically an hour, and that's what we need in order to really get down to the root of the issue, because 15 minutes is just not enough. It was never enough, honestly.
Is it ever too late to start menopause hormone therapy? Dr. Senemar.
So the way the timing hypothesis works in terms of hormone therapy is with 10 years from when your last menstrual period was. So the first 10 years after menopause, average age of menopause, 51 and a half. So that's where you're going to have the most benefit with the least amount of risk to you if you are to start hormone therapy. Because at that point, women are healthy, they don't have diabetes, they don't have heart disease, they really are not, having any other issues. So that's why we say those 10 years are great. But that does not mean if you're 61, you don't have a conversation and you're not a candidate. Yeah, there's still something we can do there. I have patients who come to me and they're 65 and they're like, "Did I miss it? Can I try this?" And they're still having symptoms, mind you. And so absolutely, we have a conversation. We do testing. I do maybe more testing on them. Evaluate their cardiac function, make sure everything is in tip-top shape. Then we do start it at that juncture and go forward. I think the other part of it is, am I done after 10 years? Do I need to come off of it? And again, the answer is no. You need to speak with your healthcare provider. Every visit you go in, okay, how's everything? Has anything changed? Any new things, medical issues that I need to be aware of? And then we decide together. Again, it is a team effort. This is not a one-sided conversation. This is about you feeling your best. And so we're there to guide you on that path.
Totally agree. So my oldest patient on hormone therapy died at the age of 103.
And did she stop hormone therapy?
Did not stop. Did not stop. And again, it's of course there are nuances to the conversation, but that's where it's important to see a provider who is open-minded, who's going to understand the risks and the benefits and help weigh those out for you and help discuss them with you. But I see this every day. I just saw a patient the other day. I am here because I was a victim of 20 years of misinformation, and I am now in my 60s, and I'd like to talk about hormones. And you might be the only practitioner who's willing to listen. So, it's devastating to hear that. 20 years.
I think of our poor mothers who
Yes.
did not have these kinds of conversations. It's criminal, Science owes us a lot, so let's start collecting. I would love to dive into what some of the benefits are, kind of top line, what you think the biggest benefits are, and then also the risks that you want to make sure women are aware of.
When we're talking about hormone therapy, we're really looking at your health, your overall health. Number one, it's all about symptoms, right? We want to feel better. We want the hot flashes to go away. We want to sleep. We want to get our mood under control so we're not, going to get fired from our job, right? Yes, but we're also looking at your health down the road. So your longevity, how are you going to be aging? We don't want to live longer. We want to live longer and healthier. So it's not lifespan, it's health span. These are all things that are out there now that we're all talking about. So health span, lifespan is just how long you live. Health span is how long you live that life and how healthy you are living it. So we want to really be addressing diseases that you're not aware of. Bone loss. We want to make sure that osteopenia doesn't happen to lead to osteoporosis, which then leads to major fractures. And we want to make sure your heart is well, so you don't get a heart attack or heart disease down the road, high blood pressure. These are the things we're monitoring when we're having these conversations with you in the exam room. It's to prevent all of this from happening to you down the road, because number one risk factor, or the number one cause of mortality in women over 51 is heart disease, okay? It's not cancer, it's heart disease. And that heart disease starts in your late 30s, early 40s, when those hormone shifts are happening, and all of a sudden you notice your LDL starts to rise, where nothing else has changed in your life. And you're like, what's going on here? Do I need to be on a medication for this? And the answer is no, let's get to the bottom of it, and this is what's happening to you. So it's really about bone loss, heart disease, and the bigger one, cognition, Alzheimer's, dementia. We're seeing this over and over again. There's a lot of research going into that right now that is actually the newer things that have been coming out is that it depends on when the hormones are started. If it's started early in the menopause transition, then it is beneficial. If it started later, it's actually detrimental. So again, conversations that you need to be having with your provider who's actually watching the research and not just, oh no, that's not there, we didn't do that, we don't do it, so you don't need it.
Yeah,
Dr. Tolentino, I'll throw to you for the risks.
The risks. I mean, there's always risks. And that's where it, becomes a one-on-one conversation. We think of clotting factors as being a risk, those with really high-risk cardiovascular disease as being a risk. Certain types of cancers can be a risk. When people are deciding to start on hormone replacement, it's always step number one, the bedrock, lay the foundation for all of the lifestyle things. And then when you talk about the hormones and you're looking at the data, you're looking at the person in front of you. What is their own personal risk? Have they been on any sort of medications that could be problematic? Are we also thinking about what their family history is like? So there are many different risks that don't apply to everyone, and that's why it always becomes a conversation between you and your doctor to determine your own unique risk.
If you could talk to someone who is just gut afraid of going on hormone therapy, I know there are a lot of women because for so long we couldn't even talk about hormones, right? They were so scary, they were gonna, cause cancer and all sorts of other things. What would you say to reassure her?
I would really just educate her and have her understand her risks and her benefits individually, because I have patients who come to me and say, I'm not a candidate. They tell me themselves right off the bat. And I ask them, why? Why do you think you're not a candidate? Well, my mom had X, Y, and Z. Okay, but did your mother get tested? Did we have any genetic background? Oh yeah, it wasn't a genetic related mutation in her breast cancer. Okay, so let's test you and see what your genetic background looks like, and then have a conversation. So I want them to at least have heard it when they walk out of my office. Then I feel like I did my job. Now, whether they go on it or not, that's their personal choice. And I will do everything to show them the benefit of being on hormones can do for them. So I would do a bone density. And let's say they have osteopenia already. That's another point for the pro to be on it, okay? So I would just really help them understand the benefits and really try to minimize the risk for them, especially if it's usually not there.
I mean, we have hormones coursing throughout our bodies, doing these chemical signals everywhere, all the time. Every single one of us right now, we're experiencing that. If we are pregnant, we experience a flood of hormones. There are so many situations where hormones are present in everything. Your metabolism, your immune system, you name it. So I think the fear around it has always just been that stigma from the last 20 years. But as we are unveiling and looking under the hood and really understanding, is it truly something that we should fear? We're not seeing that. We all have hormones that are coursing throughout our bodies right now. And so the more that we get away from that fear mindset or even the shame for having these discussions, it becomes a part of a longer, bigger conversation about your health, because hormones do run the show.
All right, for our final question, I'd like for each of you to share what you think is going to happen in terms of the evolution of hormone therapy for both perimenopause and menopause. What are you excited to see as kind of the next wave of care for women going through these transitions? Dr. Tolentino?
I can't wait to see it part of every single conversation. every single conversation that people have with their doctors, that it becomes just part of the conversation instead of it just being something siloed or gaslit or let's not even go there or let's not talk about it. Every conversation even means for breast cancer patients.
And in 2025, that doesn't feel like too much to ask for.
No.
Yet.
So I think the one thing I would want women to understand and just kind of walk away with is that it's going to be okay. You're gonna get through this, and we're going to feel better. This is not just about surviving this. This is about shining and thriving on the other side of this. So just stick to it and ask all the right questions.
Wonderful. Well, thank you both for this conversation today.